on the show, we'll be focusing on leaders who are addressing some of the city's core problems, looking at homelessness and emergency response. Spotlight Now starts now.
You're watching Spotlight Now with Ryan Kalei-Suchi and Yunji Denise on Hawaii News Now. Have questions or comments for our guests? Join the conversation in our Facebook live stream. Spotlight Now, where Hawaii comes to talk.
Aloha and welcome to Spotlight Now on Hawaii News Now. Ryan Suji is off today, but our show continues, and we are starting out with Dr. Jim Ireland from EMS. Thank you so much for being here today.
Thank you.
We've got a lot to talk about, and of course, we always welcome our viewers to put their comments and questions in our Facebook chat. Let's get started with the basics, Director. How is EMS doing? We know that this is a city department that is so important to the city and yet often so under-resourced. How would you assess where the department is right now?
You know, we have 30 minutes. First of all, the paramedics, EMTs, or dispatchers work hard every day to just answer the call, take care of people, save lives, and it's such important work. But you know, EMS nationally has had some trouble, and we're not immune to that. And by trouble, I mean that we're the social safety net, and more people are using EMS for every medical problem, whether it's an emergency or not. Have a toothache, call 911, have EMS come. Constipation, a little cold, stuff that maybe you or I would go to a PCP for, a primary doctor or an urgent care, people are calling 911. And so probably 100 of our calls a day out of 300 are not true emergencies. And what that's doing to our system and what we need to find solutions for, and I'm working very hard at, is how do we address the folks who are calling for non-emergencies and how do we respond to that? You know, some of our crews are running a call an hour, which is really, I wouldn't say unheard of, but usually one call every 2 or 3 hours is kind of a normal pace for most EMS systems, or less, you know, maybe even a call every 3 or 4 hours. And them doing a call an hour, especially in the town areas, it's just too many calls. And so, you know, one of the goals I have is how do we offload those calls either to non-emergency providers, to a nurse navigator line, a helpline, or just adding additional resources, maybe basic life support ambulances without paramedics, to address those folks who need help but don't have a life-threatening situation that needs a paramedic. And I'll give you an example, and I thought about this before I came. You know, you do this show, we all love it, it's a great show. You spend an hour here, you probably had to prepare for today, you get compensated, I'm sure. But imagine if you had to do 8 or 10 of these a day. For a day it might be okay, it might be kind of fun. But then day after day after day, if you're walking into that much work, no matter how much you love your job, it's just going to take a toll. And that's what we're seeing. People get into EMS because they like it. People stay in EMS because they love it. And so I feel my role and the leadership's role in our department is how do we make the best conditions possible for our employees so they can do what we're asking and deliver that life-saving care.
You know, and I think for people watching, they may not understand that even if someone is calling for some of the minor issues that you're talking about, you can't dismiss them and just hang up the phone or say that's not an emergency, call someone else. You have to respond to each call that the folks are each caller as if it is an emergency. We do.
Now, abusive callers, if they're calling every hour, and just, you know, that kind of thing, we do actually will ultimately send the police to deal with that. But everybody's definition of emergency is different. But again, yes, we respond to all the emergencies. And the other issue is, you know, paramedics by nature are smart. They're independent. They know how to take control of scenes and be in command of a situation. And so these are highly desirable employees by any profession, other healthcare professions, as well as, you know, like the fire department, nursing, even as physicians. And so we're in constant competition to retain employees in EMS, and not just us, the private EMS providers and others. And how do we do that? And one of the ways that, you know, I think needs addressing is what people are compensated in EMS. And we're having some negotiations now. It's still in negotiations, so I don't really want to go too deep into that. But we need to get our paramedics, EMTs, and dispatchers paid more. Takes about 4 years to become a paramedic from the day you decide, hey, I want to do this. And in that same 4 years, you could get educated and be, for instance, a nurse. Now, it's similar careers, but it is different. But there's a pay gap between a paramedic and a nurse. And so we're losing people to nursing. So as an administrator, how do we bridge that pay gap? And so that's one of my goals. Not necessarily that we're going to make the same as these other professions, what are a little different, but at least bridge the gap to retain the people. You know, our vacancy rate is the lowest it's been in 10 years or more. We have 18 people starting next week. Our vacancies will be around 20, the low 20s. We have 25 recruits starting in July. So, you know, that really puts our vacancies at single digit, which is great. Staff the ambulances, but we also want to expand, and we need to expand because one of the ways of lowering the call volume is just adding more ambulances in the system. So the mayor, in our budget, we have a Kaimuki ambulance proposed, but some of the council members have also discussed with us what they call a council ad, where they put money in the budget. Council member Kia Aina is advocating for an ambulance on the windward side. Also Tupola and Wire also for their districts respectively. And so even if we get to 0 vacancies or close to 0 vacancies later this year, if we're going to expand into next year and beyond, we need to keep hiring.
There's the personnel, and then there's also the equipment, because you're dealing with some very expensive equipment. To add another rig, I would imagine that you'd need a lot of money for that. How are you doing in terms of the facilities and the money that you need for that?
It's good. And, you know, one of the things that I'm excited about is I just got off the phone with our team that's in the mainland right now. And they are inspecting 14 ambulances. 14, 6, 8, yeah, 14. And those will start arriving here in the next 2 weeks. So 14 ambulances, 6 are brand new, and I think the other 8 are what's called remounts, where we took a older box that's still good and remounted it on a brand new chassis. He said they all look new. They all look great. So that'll be 14 new ambulances in the fleet in the next few weeks, physical ambulances. We have 4 more remounts scheduled for this summer, and then we have 11 scheduled in next year's budget. So we have the potential to have the entire fleet of ambulances, 23 ambulances on the field under 1 year old within a year. So definitely have to get the best equipment for our paramedics, whether it's the monitor, the life pack, the intubation equipment, or the ambulances. And so that's actually coming together quite nicely. So it's good.
One of the things that was supposed to help to alleviate some of this call volume was the CORE program, to kind of divert some of those instances, because we do know that there's been a lot of calls from homeless individuals who need care or maybe want to ride to the hospital to then get medical services or a shower or what have you. You've talked about this on this program and elsewhere. Has that worked? You know, how many calls do you think, or, you know, I know you can't say exactly how many, but do you think that it is diverting some of that workload? Has it been effective?
Yeah, it's absolutely working, but we want more. So the CORE ambulance on duty, we have one dedicated for 911 CORE calls or homeless calls. They're doing anywhere from 3 to 6 calls a day out of the system. We have a second CORE ambulance that focuses more on non-911 type responses, like complaints from the public, people in parks and things. So that's just the daily. But also by putting patients who are calling all the time in our medical respites, that short circuits calls. So all our respite has about 60 patients. Our Liahi Hospital respite has about 20 patients. So those 80 patients, some of them are calling 911 every day. And so when you multiply that out, that's hundreds, if not thousands, of 911 calls that aren't happening. So it's definitely having an impact, but our goal is to have more of an impact.
Yeah, and it's interesting because when you think about, 60 to 80 individuals, that doesn't sound like such a large number, but what you're telling me is that if you have someone like that calling every day, if you're getting 300 calls and you could take out, a significant number, what kind of a cost savings does that mean for the public?
Oh, it's in the millions for sure, because an ambulance ride, the bill is about a little over $2,000, an ER visit about the same. Once you do medical tests and doctors and things, that 911 call ends up costing maybe $5,000. And you multiply that by thousands, that quickly gets up into the millions. So the savings is there. It's a good return on investment. And again, we need to do more, because as successful as we are, I still look down King Street and I'm not happy with the tents and the people there that are really suffering. And so we need to keep expanding.
How much expansion would you like to see?
Well, the team is right-sized now. We are planning on putting a hub in Waipahu, so we're going to go out and have a west side presence to cover central Oahu and more the west side of Oahu. But I think the focus moving forward is how much more respite and shelter space can we get, so we have places to put people. And then also the programs that reunite people with their families on the mainland. We need to look more into that and expand that, because people come here on a one-way ticket, they think it's paradise, and then they're homeless. And they don't have support here, they don't have family here. So getting them reunited with their loved ones and support on the mainland, Marshall Islands, Samoa, those places is also a strategy that I think we need to expand.
How much of the call volume do you think are folks like that, and how many are Kama'aina? Do we know?
You know, people know, and just a very rough guess, probably a third, 25% to 33% are probably have been here less than a year, and especially like the calls in Waikiki and downtown, very much so. They're usually here just a few months. When we go to other neighborhoods, like particularly the west side of Oahu, most of those people were born and raised on the west side of Oahu. So different populations in different areas geographically, but definitely downtown, Moilili, Waikiki, enriched for people who have not lived here very long.
Wow. Let's talk a little bit about your leadership. You are up for reappointment. Tell us a little bit about why you want to continue to do what you're doing.
Well, you know, it's just such a privilege to support the paramedics, the EMTs, and the dispatchers, and work for them to try to get them the things they need to do their job. I know it's frustrating still yet for them because just, again, the call volume is so high, but trying to get more ambulances on the road, get more personnel hired. You know, a lot of people saw my confirmation hearing and had some ex-employees and said some things that was a little rough. But, you know, I stand by, for instance, the work environment. You know, it's not a toxic work environment. I have an open door policy. Everybody knows they can come talk to me. I get out in the field when I can to see people in their working environment, see their working conditions, and it really makes me appreciate them even more because I see how hard they work. You know, I don't make a secret of my medical practice. I was a doctor before I came to the city. I'll be a doctor after I leave the city, and it's important for me to keep those skills up. And so there is a practice that I own that I work at from time to time, usually maybe twice a month. I'm contracted with Waianae Comp, where I go provide specialty care there for that population a half a day a month. And I just make sure I'm not employed by the city on those days. Either I'm on vacation or it's a day off. So there's no, you know, financial conflict or any ethical problems. But I enjoy medicine just as much as I enjoy working at the city and EMS. So, you know, want to continue doing that. You know, very limited, but still. So when I do someday leave the city, I'm able to just kind of step right back into being a physician because I enjoy that.
Let's talk a little bit about, well, I want to unpack two things that you said, the private practice that you have, but also the work environment. Were you surprised by that testimony, and you know, how would you respond to that? Because there was, you know, some folks who seemed quite upset.
Yeah, you know, and again, all ex-employees, and I heard what they were saying, but it's just, you know, that environment is just completely untrue. You know, we do investigations, and there was some, I think, target investigations, allegations, but you know, when we get complaints, it may come from a patient, it may come from a coworker, it may come from the public, a doctor, a nurse, and we follow up on all of them. And most of them are, first of all, they're few and far between. And most of them are manini, meaning small. Somebody came late to work, somebody was out of uniform, and we address those with what's called oral counseling. Those never even come to my desk. We tell the people, hey, you know, you need to be on time, and find out why they were late or out of uniform. Real small stuff. And more serious things maybe, and again, these are so rare, but once or twice a year, maybe someone may not follow what we call the standing orders, and certain medications you can only give when a doctor says it's okay, and others you can give without the doctor's okay order, and maybe they get out of sequence, and that again is usually just something that may or may not even come to my desk. But unfortunately, we've had other serious investigations that do come to my desk, and we have to investigate, and we have to take action. And I would say that's like the worst part of my job, having to do discipline. But we've, over the last 4 years, had a few investigations for sexual harassment. Those employees are no longer with us. We've had a few investigations for drug use. Those employees are no longer with us. And so there's a line where even if we, you know, like the person, if they're a good person otherwise, you just can't tolerate that in the workplace, even if it's government, even if they have, you know, represented by the union. And we just have to take action. And I think not to do that is doing a disservice to everybody else who's, you know, the 99% of the employees who are really hardworking and do such a great job. And again, I just want to stress too that I get probably 10 letters of thanks for our paramedics and what they're doing for every one maybe complaint I get. And again, some of the complaints are very, what I would consider minor. Oh, I wanted to go to this hospital and I had to go to this hospital. So the really serious stuff is few and far between, but we're not immune from it, just like many other agencies and workplaces.
How are you able to balance, running a clinic, and also and doing the Waianae Coast work, and then also running this department, because this seems like a job and a half on its own. Why not just step away from the private work entirely until this position is finished?
Yeah. Well, with Waianae Comp, I show up and I do 5 hours of work and I take care of patients, and then I'm done for the month. And that's something I've done for 10 years. It's an underserved community. There's a huge doctor shortage on Oahu and actually the whole state, and that prevents literally hundreds of patients from having to drive into town or other places to get care. And I just, it's an honor to work for them, and a privilege to work out on that coast. Private practice, again, I don't run it. I don't work there on the daily. There's other doctors that work for me, mid-level providers. And again, I go usually like two half days a month, and we'll see patients there. But again, it's not on city time. It's something I enjoy, and it's something I'm going to do when I leave the city. So not so much in the administrative work. My administrative life is actually with the city.
Given the tone of that hearing, have you had some discussions with city leadership since then, council members or the mayor? I know that you have the support of the mayor in your reappointment, but what have those conversations been like in the time since?
I've got a lot of calls from friends, coworkers, old friends, government leaders, hotel industry, and just thanking me for what I've done. They were people who know me and people who have worked for me, knew that a lot of that wasn't true. But the mayor's been very supportive. I got a call from the governor, was very supportive, as well as again a lot of the hospital leaders, and so that was encouraging, because to hear that I was like, wow, that's not true, and why do I even want to put myself out there and to have to hear that when we're all working so hard to really do a good job for the city. I probably work 6 days a week for the city, and way more than 40 or 50 hours. New Year's Eve, midnight, have a nice party with my family. 1 minute after midnight, get dressed and go to work, and didn't get home till 6 in the morning, as did our deputy director, as did our chief of operations, as did Shane, actually it wasn't Shane, it was Sunny. Shane was on vacation, so it would have been Shane, but it was Sunny that night. And the whole team just comes together at midnight and works all night because we had an emergency in the community. And if we would have called in paramedics off duty, if it was a bigger emergency, they would have come in too. And we did have some off-duty people come. So I in my mind, there's no doubt I'm putting in full-time for the city and more. But I think that's true with many of the directors in the city. And I think many directors put in time on the weekends, and just because there's so much work and they have so much pride in their department, like I do, that you just want to do a good job for the city and really for the employees and for the mayor.
Yeah, and that kind of goes to, what you were talking about earlier with paramedics perhaps being able, people with the same skill set being able to make a lot more money as a nurse or in a different, in a related industry but not the same one. The same would be true for you, I would imagine, if you were not the director of this and you were working, in private practice as a physician full time. I would imagine that the compensation would be higher. So what keeps you wanting to do this and wanting to continue this position?
It's such an important role that paramedics play, and EMTs and dispatchers, the whole team, for our community. And it's really a privilege to be working with them and for them. And it's really my job to support them. And it brings me a lot of enjoyment, personal fulfillment. I enjoy seeing them work in the field and the good work they do. And again, I'm also the one who gets all the thank you letters. And hey, thank you for saving my mother's life. Thank you for, and even when they can't save the person in those situations where they do all they can and the person didn't make it, I still get letters thanking me for the compassion and for explaining the process of what happens if someone's already passed away and how to get a funeral home and a mortuary. The person's already passed away and we go and there's nothing we can do. I still get letters from those people because our paramedics did something for that family that they didn't have to, but because they cared.
Yeah, and as you are recruiting folks for this job, given all the challenges that we've just laid out, what is your pitch to folks who are interested in this profession and maybe deciding one way or another?
I'm surprised more people don't want to do it because, it's so fulfilling. You never have a day that's the same. You're out and about. And again, people get into EMS because they like it, but they stay in it because they love it. And it's hard to love it when you're so busy. And so that's why really all of our focus, most of my focus in the next year is how do we get the paramedics, EMTs, and dispatchers more compensation? And how do we offload some of that work, spread it out a little bit with more units or other ways to get people the help they need that's not necessarily the ambulance. But again, just working for them and helping support them is just really a joy.
I want to go back to something that you said, and that was bringing up the incident in Iliamanu on New Year's Eve.
Yep.
I'm interested because now the latest patient, the last patient from Arizona has been discharged, we understand. We've had 6 people who died, including a 3-year-old. Just a really, really tough situation for the entire community, a really shocking incident. You were there that night. Can you tell us a little bit about, the response and what you've been thinking about in the time since?
There were actually 40 patients there, about 20 that EMS handled, 21, and all of them were critical. The ones EMS handled were all critical. The people who had minor injuries got onto the hospital themselves. But the massive scale of that was not something like I could imagine. When you think of mass casualty incidents, you think of a bus accident or a boat flipping over or some natural disaster. But just that scenario, although I guess it's plausible, and we see firework injuries every night, every New Year's, but like 5, 6, 1, maybe 2 people at the same scene. So that when the first people got on scene for that, and they said they had 6 critical patients, that's when I told my wife, okay, I'm gonna go in, and the scale, and then when I got there, just how bad the injuries were. Clothes were burned off, skin was burned off. These were critically ill patients. And so that's hard to see for anybody, because I'm a human being, our paramedics, EMTs, we're all human beings. And they're all professional, they take care of the patients, they do the best they can. But afterwards, there's a period of reflection, and we call in our peer support, and because mental health is also an important part of EMS and making sure our folks are okay after. And I don't know, if we rewind back to that week, we had an aviation accident the week before, very tragic, and we lost a firefighter. It's tough.
Yeah.
The next week.
What kind of care are you giving yourself and also your staff in this? Because I can tell that, this is a very emotional, this is an emotional thing to reflect on.
We have a great peer support team. Rachel Ortiz, Jenna Altamari, and their team. We have a dog. They bring a dog. I don't know what the dog's name is, but it's a cute dog. And whenever we have a highly, what's the word? A call that's just out of the ordinary. I mean, there's no ordinary call in EMS, but if we have a pediatric death, a critical pediatric, like the e-bike accident in Neva Beach, a 7-year-old, or a family or friend of EMS, an EMS employee, firefighter, police officer, somebody we know and work with, or something that's just kind of extra tragic, we deploy them on short notice. And they sometimes know minutes after this type of call, and they'll go to the hospital and meet our teams. They will engage me included afterwards, and just to talk about things and let that out. And it was important to me too that they included me. So they circled back and said, "Hey, can we talk to you?" And I was like, "Yeah, come in. How are you doing?" I said, "Oh, you're gonna debrief me?" And they smiled, and I smiled, and I appreciated it because it affected all of us.
What do you wish people understood about these fireworks? I know that, if not this, then what? That's sort of been the conversation that I've been having with leaders about, illegal aerials in general. Do you think that this will be a turning point for the community? And what do you wish folks understood as someone who was there that night about, because theoretically you can imagine what that was like, but it's very different even just the conversation that we're having right now. I can see how deeply this affected you, and you've been a doctor for many years.
Well, like I said, we get firework injuries every New Year's, and every time they're popping, we get 1 to 6 significant injuries. People blow their hands off, they get hit in the face with an aerial. not every year we lose a life, but some years, and besides this incident in Salt Lake, somebody lost their life that night too, like an hour or two before. And I don't think people really imagine that you could like blow up your whole neighborhood and like kill your neighbors and kill your family members. And that, I mean, I saw news reports that something like 500 pounds of fireworks there or more. So just that volume of explosives, maybe people didn't quite appreciate the dangerousness of that. And then there's also the civil liability. So there's just so many reasons, and now potentially even heightened criminal penalties. So I think all the more so that we, what the governor said is let's just have more professional firework displays. People can enjoy it. You'll still see everything, but maybe not like in every neighborhood on Oahu.
I know that we've kind of veered off topic, but I want to ask you also about e-bikes, since you brought that up, and it's something that we're seeing more and more of. And what's so interesting is when you drive around, there are all these motorized vehicles that you see. I'll see someone on what looks almost like a unicycle, different e-bikes, some in traffic, some on the sidewalk. A lot of kids are getting these. We wouldn't give a kid a moped, but some of these are going just as fast as a slow moped in traffic. What are your concerns, and what are your paramedics seeing in these accidents? We know we had the fatality, but there are other incidents that are happening as well.
So there's e-bikes, which generally go under, I think, 28 miles an hour. And then there's e-motorcycles, and these are the ones flying down the road at 50, 60 miles an hour. There's the unicycle, which is like one wheel. Then there's e-scooters, and not the motorized scooters like mobility, but the like you stand up on. They have outpaced regulation. So it's kind of has been a free-for-all. The city council with Tyler DeSantos Tam, Councilmember Tam with his leadership, Councilmember Tolba on the west side have been very active, as well as others in getting ahead of this, trying to get ahead of this. So we do have now some stuff for e-bikes, but it's still a little wild with the e-motorcycles. And we saw this big, I don't know what it was in Eva Beach, but we had a patient from that, I believe. I think we took one person to the hospital. So there just has to be some corralling of this activity. I mean, they're green, safe, generally a safe method of transportation, but no helmets, riding crazy in the streets, young kids are a recipe for problems. And we're getting accidents probably every other day, serious accidents with a e-vehicle of some sort.
Every other day?
Every other day.
Are these mostly children, or they sort of run the gamut? Who's riding these?
I saw one about 2 weeks ago, and it was an older, it was a woman. And I think she was delivering like for a food service, like one of those Dine Dash things or DoorDash. And she was going down King Street in the green lane, and someone turned in, and she ended up under the car. And she was in an e-scooter. We see children, young kids on the e-bikes and e-motorcycles. Young meaning anywhere from 7 or 8 up to 14. All illegal to be on those. And then we're just seeing a mix of adults. So yeah, kind of everybody. But the kids are the ones getting in some of the worst traffic accidents because they don't understand traffic laws. They're out on the street. They don't understand what the cars are supposed to be doing and the concept of lanes and yielding. And so the really young kids under 14 who don't even have a driver's license or around that age are the ones really sometimes getting into the horrific accidents because they'll impact a car.
It's interesting to me to hear you speak today. I've been covering this department for a long time, and I think you are probably the most active director I've seen in terms of responding to the calls yourself. Why do you like to go and actually deliver the care yourself?
Well, 95% of our workforce is not in the office. So if I spent my whole time in the office, how are you interacting and knowing your workforce? And so I go out and ride with our supervisors. I'll go out myself. I'll go out with our PIO and their team. And every now and then I'm just, I guess, right place at the right time, where I'm the only one there from EMS, and I'll render care, and I'm very comfortable doing that. We had a cardiac arrest in City Council, and I grabbed an AED, or somebody grabbed it for me, and fire chief did CPR. I put the AED on, I shocked the gentleman, and he came back right away, and it was very gratifying. And so, again, I'm still a physician. I'm actually still a licensed EMT, so I'm licensed and legal to work on an ambulance, even though I haven't done that. I did it during COVID a little bit for the city, but I haven't done that lately. But again, just being out with the workforce, seeing what they do, helps me to understand their challenges and struggles and where I need to advocate the strongest.
I think that's a good place to leave our conversation today. Thank you so much, Dr. Jim Ireland, for being with us. Connie Mitchell joins us after the break. We'll be talking about homeless services in the city. Stay with us. You're watching Spotlight Now.
Where's the
Welcome back to Spotlight Now on Hawaii News Now. We are joined now live by Connie Mitchell, who is the director of the Institute for Human Services. Connie, thanks for being here.
Glad to be here, Angie.
I want to talk about some of the stuff that Dr. Ireland, some of the issues that Dr. Ireland had raised in regards to the core program and what that's doing when it comes to alleviating some of the stresses on EMS and the homeless. But first, from your vantage point, how are we doing as a community when it comes to addressing this issue that seems to just continue on year after year?
Sure. I think we do well with the resources that are given, but we could just do so much better if there were more resources. And when I talk about that, that's, whether it's people or whether it's funding, we just need more. It's just really hard to do the work. And I think my approach is, we need the whole community behind us and really partnering, and all the service providers partnering with each other. Mm-hmm. Yeah.
And I know that you have opened a number of new facilities. Tell us a little bit about sort of the new initiatives that you're working on and what you're hoping that they're going to address.
Okay. Well, in the last couple of months, we opened 2 new kauhale. One of them was with the state, Alana Olopono, and it's a 45-bed or 45 units of those tiny homes in Iwalei. And that one, we really wanted to have people who really want to come off the street. Maybe some of them were working, living in their cars. Some of them were younger people, that are transition age youth. Just in general, some people that really didn't have an opportunity, didn't feel comfortable in some of the congregate shelters that we had. And, it's been doing really well. I think we have about 28 people over there right now. And we've already exited some people to housing in the short time that we've been there. The other one is Kumu'ulaho, and that one is a another shelter that really focuses on people who have had a lot of trauma, and so brain injury, maybe stroke, or even some people who just are experiencing dementia, so a lot of recovery that's needed, and it's really based on principles of promoting neuroplasticity and a lot of brain science. So we're partnered with Bihari, or the Brain Health Applied Research Institute. And so it's kind of fun to be doing some really different things and providing some different kinds of shelters for very specific people.
Yeah, the Bihari folks, audience, if you have not had a chance, check out their website. It is such an innovative way of looking at the brain, looking at architecture and
Right.
science and
Yep.
how it all melds together. So these facilities sound fantastic. When we look out at the homeless population, what do you think are the main issues that are, causing us to continue, that this issue continues in perpetuity, it feels like? Is it drugs and alcohol? Is it mental illness? Is it all of the above, poverty? Like, where do we go? What is the sort of linchpin of all of this?
So I think the complexities have definitely increased. Even in the time that I've been doing homeless services, which is almost 19 years, we've seen so much evolution. But the problem with just not having enough housing is something that's been with us before the last World War II, right? And someone was just telling me there was an article that said we had a shortage of housing back then, and I'm thinking, well, we still have that shortage, and it's grown a lot, and our population has grown. So I think without really a concerted effort to build more housing, we're just always going to have this problem of homelessness with us. All the things you mentioned, substance abuse, mental illness, people who are having medical crises, people who have relationship crises, anybody who is living with somebody else right now who needs two incomes to basically be able to pay the rent. If somebody, that a couple breaks up, or someone dies, they're at risk for homelessness a lot of the time.
We've talked about substance abuse on this program before. What are you seeing when it comes to drug use in our community, and how much do you think that's contributing to this issue?
Oh, I really see it as a significant problem. For me, we're dealing with people who are using drugs that are just so much more potent these days. We didn't have the problem of opioids and fentanyl and, things that would just cause so much overdoses. We've seen that climb in the last couple years. But even the things that were so benign, or we thought so, like marijuana, is a lot stronger these days. They're tainted with other drugs, or, they use it in combination. Even the meth is a lot stronger and more potent. They're coming from labs that are not the way that they used to do it before, where they did it at home. So the potency is just really scary. I mean, a lot of times, people are just really in the shelters. Some of our guests, they're just really nice people, and then all of a sudden they have an episode, and there's a incident, and we think, what happened? And I think they got their hands on some meth. The other thing is that a lot of people who are coming from the continent, and they are here and they're new, and they get hit up to say, hey, why don't you try this? It'll keep you up at night, so you don't have to worry if you're on the street. And then they're hooked, and people are getting on methamphetamine. So it's just really challenging. I think the behaviors that we see, that's what concerns me the most. The amount of violence, the lack of control, the impulsivity is just very, very disheartening.
The homeless treatment center that you opened over a year ago, that is a detox facility, that's my understanding. How many people are you able to see, and what happens to those people after they go through that initial treatment? Do we have a place to send them to so that care can continue?
I'd love to share with you, Angie, in the, I guess a little more than a year and a half that we've been open, we've probably served over 300 or 350, in that little triage center. And we've had so much success. We've had about 80% success, in terms of people who actually finish their detox and withdrawal management. And it's that medically supported withdrawal management that's the real key, because it's so hard to get off of some of these drugs now because of the potency, that you really do need some medication to just get you through the worst of it, because people are convulsing. They're, really sick, really physically sick when they're going through the withdrawal. So having that, help of medications just makes the difference in so many instances. But it's not just the medication. The staff there are very, very loving, and they really do support people wholeheartedly. And you mentioned where do they go afterward. From the day one when they come in, we're already thinking about, okay, where should this person go? And we use every kind of disposition to help them find the right place to go to continue that treatment after they're finished with us, because they're only with us for about a week, 5 to 7 days, and after that it's like they're really ready for real treatment. And I think a lot of the treatment centers, they really understand that when somebody's been helped through the withdrawal process, they're a much better candidate to go through residential treatment also. So for me, it's been a pathway out for a lot of people on the street that I don't think they ever would have come off the street otherwise.
So there's the drugs and alcohol issue, and then there's the mental health component. And it's not that I'm sure that there's a Venn diagram where there's a lot of overlap. But I know that you and I have talked in past episodes where there had been a push to try to get people on medication for schizophrenia, let's say, on the street. So how is that going, and is that proving to be effective?
Funny you should ask. I was just at the NAMI conference yesterday with Dr. Chad Koyanagi, and we were just talking about, the progress that ACT has made over the years. It's been a while since that bill has passed, and we've been at it. And every year we think about, okay, how can we make this a little bit easier to make happen for some people? And we have, like I think the program's been running. Maybe for about 5 years or so, that we have that's funded by the city. And we have gone through, we've actually been awarded about 50 of those assisted community treatment orders by the family court. But that's not the only people that get the benefit of the program, because ACT is only for those people who we can't actually get to take the medication on its own. And when we're talking about medication, of course, we're talking about long-acting injectable medications that are antipsychotics for people who have schizophrenia or schizoaffective disorder. And I think for a lot of them, it's been, again, another way off the street that otherwise they never would have come off the street. I remember one gentleman, in Waikiki, he was just not functioning at all, on the street for a long time. And then we started giving him the shots, and he's now working. And so I'm just kind of amazed, that can happen.
Wow, that is so powerful.
Yeah.
So there's the mental health piece, the drugs and alcohol piece, and there's also the poverty piece.
Yes.
And you and I have spoken about kupuna in our community. It's one thing if you get clean and sober, or if you have your mental health issues addressed, that you can go out and get a job.
Right.
But some of the seniors out there, either for age or for disabilities or what have you, they don't really have any sort of economic prospects. And I know that you have seen an increase in the elderly in your facilities. How is that going? What is the profile there? And has there been any change since the last time we talked?
Change, not in a good way. I'd say, probably about 30% of our guests in the congregate shelters, are over the age of 55. And in our medical respite, that number jumps to about 70% or so.
70%?
70%. That's medical respite, people coming out of the hospital. Tragic, as far as I'm concerned. There are so many people who are, well, first of all, our population is aging anyway. So we have a lot more people who are in that category. And then you have people who worked all their lives, and they're thinking, okay, I'm going to retire now, and I have an apartment, and they've been living there for a long time. And then, the rent goes up, and it keeps creeping up, or it jumps up, all of a sudden by a few $100s, and it's just something they can't afford because they're on a fixed Social Security income, right? So I think it's really important that we really try to help some of the kupuna have a different, I guess a different option, so that they don't have to really, worry about the fact that they're just maybe becoming homeless. But that is really sad to see them.
What's interesting is under the Ige administration, we really saw a push to helping people with young children, right? Because we saw these terrible scenes in Kaka'ako, Kaka'ako Makai, where there were children on the street, and you could, and so it was very visible. And that administration did a lot of outreach and efforts to really help young children.
That.
And I think that they were very successful in if you looked at some of the press releases that came out toward the end, and those are real people behind those numbers, that they had been very successful. Do you think that there is similar sympathy and sort of push to help seniors? In Hawaii, we talk about so much about how we love ohana, how we
Right.
care for our kupuna, but when you tell me that 70% of the folks in that
Medical
facility
respite.
are over the age of 55 and may not have, is it a lack of family, a lack of relationships? What is is it pure poverty? What is the core of this issue, do you think? And how could we address this?
I think it is the disconnectedness of our relationships. Many of those people, like you said, they are alone. Their children are not here. And then also, I think people are just more isolated. They aren't connecting. Before there were churches that, people were attending. Now, not that many people maybe go as much. Sometimes it's just the mobility issues. When people start to not be able to get around too often, then they just don't. Excuse me. So I think there's a lot of different reasons, I think, for that. But ultimately, it is a disconnectedness, a social disconnectedness. And we're also busy. People are not really doing that. I mean, my own mother, my sister calls her from the mainland every day, just so that she'll have that stimulation, another person that she can talk to. So I just think that it's really important that we're very intentional about trying to figure out the different solutions for different situations that seniors are experiencing. I think for some of them, it will be, really trying to create more what I call public assisted housing, where people have their own unit maybe, but in, an apartment building, much like assisted living that people who have money can afford. We need places, for people who may not have as much money to be able to enjoy the same kind of social connectedness, where there's a large dining hall where people get together, or, there's things where they can do together, facilitated by other staff. But I do think that will, in the long run, really help us, because the longer people can stay mobile and, really doing more things, their health is just that much better. They say that if you're isolated, I think this is from the World Health Organization, if you don't have the support of people around you, it's like smoking like 15 cigarettes a day, and it's really detrimental to a person's health.
The previous Surgeon General did warn the country about the epidemic of loneliness,
Yes.
and that's really, the core issue that you're speaking to. What's also concerning, I think, and you did mention, Hawaii, we live the longest, for better or worse,
Yeah.
right? And so that's a blessing, but obviously, from a social services point of view, that could be very difficult, especially these are folks who may not transition out of a shelter, right? And also may have some long-term health issues. Memory care, for instance.
Yep.
Are you, do you think that the state is set up and that our social services are set up to handle that influx of people who are there now and who are coming, given what you just laid out?
If you ask me right now, we're not. We're definitely not prepared. And I think we really do need to invest more resources, in those kinds of services. I think it will really pay off in the long run, because it's just too expensive, to have to support a lot of people who are very disabled or not functional. So I think I really am very optimistic in the sense that in Hawaii there is, an inherent willingness, to share, and a willingness to really care about other people. So, my hope kind of is really hanging on that there will be people who step forward, young people who want to go into the field, of really helping with people who are aging. We need more people. We need more health workers. I need more health workers in the homeless services field. That's not an easy thing to do. And, Dr. Ireland in the previous session was talking about how, they need more EMS workers. And I think for us, we certainly need more homeless service workers as well. And, they certainly don't make as much money as other people too. And so it's really trying to figure out, how we're able to build affordability into people's lives who are giving so much, to our community in that way. And I think kind of weaving that in with the housing development, the more housing development that is, like set aside for first responders, for police, nurses, firefighters, and the like, I think giving people the opportunity, to have housing is going to make a huge difference in terms of ability to recruit and retain people. So, I think that is our future, if we want it, and we're intentional about really investing in it.
Yeah, tell me a little bit about how you're seeing this legislative session. I'm also interested how you're tracking what's happening at the federal level. We've seen a lot of changes, a funding freeze for a lot of nonprofit that then profits that was then quickly reversed by a judge. But there's a lot of uncertainty when you talk to folks in the nonprofit community about the changes at the federal level, what it could mean for those services. How are you tracking that right now?
Well, I think on the federal level, there are a lot of funding that comes, to the state that's critical. We have funding that goes toward housing, our Section 8 housing, Medicaid. Those kind of programs are huge. Excuse me. And I think for the folks who are on Section 8, if they didn't have the Section 8 housing voucher, it would be very, very difficult for them to stay housed. And so I think if we think about just pulling that rug out from under people, it's going to be awful. And then for Medicaid, I think if you think about who gets covered by Medicaid, it's children, it's older people, it's families, even working people. A lot of people, they just stay on Medicaid because the amount of health insurance they get from their job, or even if they get it, they might not even get it because they're working 2 part-time jobs and they don't have the coverage. And so Medicaid really is a very much a safety net for a lot of people. Because if you have one incident, as was mentioned earlier, of going to the hospital emergency room, going and hospitalized for a couple of days, that's thousands of dollars that for people who are living paycheck to paycheck, there is no way that they emerge out of that unscathed. So I think it's really critical that, people know that those programs, those federal programs, are just really needed, and we don't have the latitude to cut a whole lot from that. We have new aspects of Medicaid that actually fund the medical respite, and if that is cut, then that's not going to happen at all. We were just about to start, funding that for a lot more people. I think homeless individuals, particularly, rely on it for substance abuse treatment, mental health treatment. The shots I was talking about are thousands of dollars, and that's not going to be possible. So I think really when we think about oh, it's not me, it's just them. It is not just them, because then the impact will be on you, because if more people are homeless, you're going to see more of them. The impact on our community will be huge.
What are you hoping when it comes to the legislative session this term? What bills are you tracking, or what initiatives are you paying close attention to?
So I think one of them is the True Cost Coalition put a bill together for us, and that one is about, it's HB 244, and it's really talking about how our budgets in nonprofit organizations, they're like a base budget that the government contracts us with, right? But over the years, the costs have gone up, and the contracts just haven't kept up. And so it's really tough. And so you have to raise more money to fill the puka. And then you really are struggling, because you're spending more time trying to raise money sometimes where, you really want to work on the, the programs. That's one we'd really like to see happen, so that, our nonprofits would be compensated in the way that they should be. Another one is HB 943, and that one is about more substance abuse disorder treatment. And it's because our Homeless Triage Center, Emil Lapija, was funded by a GIA grant, and it's a unique service in this area. But this bill isn't just about our our center. It's about the kind of substance use disorder treatment that we want to make available for everyone who needs it and wants it. And so we don't have enough beds for residential treatment. We don't have enough of the kinds of services that I was talking about either, where it's withdrawal management. That we could have one in every community. I think it would be helpful, but in any case, that's one that we'd like to see pass. And then HB 431, is really about the $50 million that was Ohana zone money that, we really want the homeless coordinator at the state level to have. All these new kahales that came out this past year, they got to get refunded so we can continue. But then it'll also allow for more kahale and different kinds of programs to be initiated. In the first year, a lot of the costs of setting up the programs are more, of course, so next year it won't cost as much to keep running these programs. But then we want to have some more money so that more of these beds could be created for people who can just then come off the street. So those four, and then finally, SD 1322 is the mental health bill that the governor's AG's office kind of helped put together, and it's really about redesigning some of the law, tweaking it a little bit to make it just that much easier for us to implement assisted community treatment, looking at examinations in the emergency department, helping EMS, be able to transport people for mental health evaluation and not have to fear, the retribution of, being accused of, malpractice or something like that. So I think it's really a lot of things that are really about implementing, funding, the things that we really need. So that's what I'm hoping for. And I know I'm just really focusing on my homeless stuff, but there's other things too.
That's a lot to track. You did mention that you've been in this space for almost 2 decades now. And I just wonder, when you look at the trajectory of what you've seen over those 2 decades, how are we doing? From your vantage point, are we at a high point, a low point? Are we getting better? Are things going in the right direction? Because the kinds of challenges that you've talked about, the substance abuse with these drugs being as strong as they are, the mental health challenges, and then the elderly. I mean, these seem like very, very complicated problems.
They are complex, and as I mentioned, the complexities are many, but and that's a big change from when I first got into this homeless business. But I think what I realize is that our policymakers are realizing the complexity. Before, people were just telling me, "Oh, Connie, all you have to do is just do this," and it's just not one thing. There's no silver bullet when it comes to homelessness. And I think more people are realizing that you really do have to come up with a diversity of solutions, and that they have to be tailored for the people. And even within one group, like, the seniors, you got a whole different, group of people. Some people have been chronically homeless for a long time. Others are experiencing it for the very first time, and the ones that are using substances, they may also be chronically homeless, or they just got sucked into something. So you really have to listen to people, hear what it is that they're dealing with, and understand what would really help them. The solution is in each person's story, I think.
Okay. Connie Mitchell, thank you so much for giving us that wide update today. Very interesting always to talk to you. I hope to get you back here soon.
Thank you so much.
Stay with us. You're watching Spotlight Now. We'll be right back after this.
From the moment you wake up.
Hawaii News Now brings you the stories that impact your day.
With more on the breaking news, we go live to Casey Lund.
Ready with the push alert? I'm going live. We have an update to the breaking news we brought you this morning on Sunrise.
Okay, guys, as soon as this wraps, toss to Mahia.
And we've been covering this story all day.
Now we go live to Mahia for a new development.
Stand by for breaking news. They just captured the suspect.
That's confirmed?
Yes, sources just confirmed it.
The news you need the moment it breaks.
Here on Hawaii News Now.
Spotlight Now with Yunji Denise and Ryan Kalei-Suchi. Connecting you with newsmakers from throughout our islands. Going in depth with Hawaii's leaders. And taking your questions live. Spotlight Now, where Hawaii comes to talk.
Very interesting discussion today with our 2 guests. We started off with Dr. Jim Ireland, Director of EMS, to talk about some of the challenges his department is facing and how they're dealing with that, talking about the staffing and resource issues. He's really fighting for some salary increases there across the board, and then talking about his own reappointment and some of the challenges that he's faced there. And he'll be going before the City Council sometime in April to see if he can get reconfirmed. We also talked to Connie Mitchell from IHS, talking about some of the issues facing the homeless population here in urban Honolulu. A lot of issues facing that community, but of course a lot of solutions as well. Great talk with our guests. We'll see you right back here next week. Aloha.